Good morning, everyone. My teachers, Padma Shri, Dr. Lahani sir, Dr. Amar Agarwal sir. It's a pleasure to have my teachers here, and it's nice to see some audience at 9 in the morning. We all do phacoemulsification, and I think the course will be about topics that we face in day-to-day surgery. Uh, So needs to have a platform. A video hai. No, thank you. So I think we will start with, so we all know and we've done routine phacoemulsification. These are some situations which we would like to present, and please do feel free to interact or ask. Dr. Lahane sir, as we all know, is a Padma Shri. He has done the largest amount of cataracts in India. Dr. Amar sir, I think, has innovated so many things and still continues to do so and gives us so many new innovations like the scaffold, the glued IOL, which really helps us. If there are more people, we'll ask Amar sir also to share his knowledge. Dr. Navneet Toshniwal is a dynamic surgeon from Sholapur. I think he trains a lot of people, has written books and innovated lots of topics, lots of new things and in his books. I'm Dr. Ragini Parekh. I was a professor and head of ophthalmology at JJ Hospital, and we retired. We continue to do the work that we've been doing. So as you can see that rhexis is the most important thing in phacoemulsification, and if you break the rhexis, you break the commitment to phaco. So you have problems with the rhexis in a hypermature cataract, as you can see over here. The cataract is very intumescent, and hence there is a difficulty. Dye is extremely important, and if you keep the dye for 20 seconds, it stains much better. After making a nick, you aspirate a little bit of the cortical matter, and then you start to do a rhexis. Now, as you can see over here, in these type of cases, it's very difficult to do a rhexis, and you don't want it to run away. The important thing in the rhexis is that you need a complete rhexis. If there is a tear anywhere and if it opens up, then it can extend. The shape, as you can see here, does not matter. The completion of the rhexis is important. In this patient, as you can see, this is a young patient with a very, very soft cataract, and phacoemulsification was not required. As you can see over here, we use the AC maintainer and the single port Lahane cannula for the manual irrigation aspiration. It maintains the anterior chamber. And since the patient was very, very young and had this cataract, this was the problem with the rhexis. But you can do the cataract surgery very well. In young patients, as you can see, even in children, you may need to use special forceps or anything that you can use to do a rhexis, maybe a rhexis forceps. This, as you can see over here, this is the use of the rhexis forceps. I wish that we can center this video. And then to manage the rhexis, as you can see over here, after the IOL is in place, the IOL acts as a buttress, like in the scaffold which Amar sir teaches. And you need to do this and manage this rhexis, because if it's a small rhexis, it can cause a capsular contraction syndrome. It can affect the visual axis. So it is safer to do this after the IOL is in place. So this is how you can manage the rhexis. The second case is what not to do again over here. So this is a hypermature cataract, as you can see again. In immature cataracts with a good glow, it's very easy to do the rhexis. Where we land into trouble is these type of cases. As you can see over here, again, since it is hypermature, we try to aspirate the fluid, which is otherwise causing the tense capsule. So you are using a needle attached to a syringe to aspirate this, and this is where the problem has occurred, because we are not very careful as to what we are doing, and the needle is extremely sharp. As you can see, when we progress with the case, you'll realize what was the problem that was created in this patient. So sometimes you may try to do something good, or you may take a decision to aspirate the cortex, but over-zealousness or over-enthusiasm because here the cataract is so soft that we did not realize the depth at which we were pushing at the needle to aspirate the fluid. And since the PC was bulging, there was a PC tear, as we can see. Now, as you can see over here, this patient probably had a traumatic issue, and that is why the capsule, as you try to do a capsulotomy, folds. And it is very loose, and hence, if it is not very tense, it gives you difficulty in doing a complete rhexis. A lot of patience is required here, because if you try to, now as you can see, we changed from the needle to the forceps. Investing into a good capsulotomy forceps, these are similar to the retina forceps. They are made by Epsilon. They are my friends. No financial interest. So this shows you this fibrosis, which was probably traumatic and which was causing all the trouble when we were operating. Luckily, the IOL is in the bag. There was no PC tear, and we could manage. Again, this is a hypermature cataract, as you can see. And this is the tunnel, extremely important, the size of the tunnel, staining of the capsule, and as I've said, that if you wait patiently for 20 seconds with an air bubble to protect the corneal endothelium, the stain would be really very good. Now here, as you can see, we are trying to be very careful, but you already see the triangle and the extension of the rhexis. That is because the cataract is very, very intumescent, and the rhexis extends. So this is the Argentinian flag sign. Now whatever you try and do, as you can see, it has now opened into a trishul type of a thing, and the only thing that remains is to salvage it, to not let any sharp tags remain, and then to do a gentle phacoemulsification. We are committed over here. The second option would have been to close this tunnel, make a superior sclerocorneal tunnel, and go with SICS if we feel that there is no. Now, if you see the flap, you can see very clearly in this video that the flap is moving. This is Dr. Rohit Om Prakash sir, who said that there is the flap motility sign, that if your flap is moving, there is no extension of the tear posteriorly, and you can go ahead with a safe phacoemulsification. Luckily, in this patient, the cataract is not very, very hard, and here you have to be very careful to use the correct ultrasonic energy, the correct aspiration energy, so that there is no mechanical push or pull on the nucleus, and you emulsify the nucleus safely. Now, what is important in phacoemulsification in any patient is the joint, or the absolute use and the correct use of the ultrasonic energy and the aspiration energy, which have to work in cohesion. So what is important is that when the rhexis is irregular or broken, you have to go slow. You have to make it circular so that there are no flaps which get entangled into the probe. You have to be very careful to maintain your chamber at all times in cases of runaway rhexis. So to conclude, rhexis is a very important part of your phacoemulsification. It has to remain circular for you to go ahead. In these cases, if you still decide to go ahead, you have to be very, very careful, because if you break the rhexis, you break the commitment to phacoemulsification. And if you are not very sure and if you are scared, then you can close the temporal tunnel and safely go ahead and do a sclerocorneal tunnel with an SICS. It's not a crime to do so. Thank you so much. Anybody would like to ask anything or share their knowledge, further knowledge regarding this with your experiences, I think they are all welcome.
Excellent talk, madam. Only one point, that whenever rhexis run away the situation, any lens you can recommend, which type of lens? Because we are fixed with one lens.
Yes. So, when like in JJ, we used to have an inventory of lenses, but even now that we are practicing, when we order lenses, there are 2-3 important things now that he has brought up this topic. That if you are using, say, example, 11 number foldable lens, you should have the same lens as standby, or you should have an inventory of lenses which are 3-piece lenses. Not in this case, in any cases, because you cannot predict a patient's complications, and you may need not to put in the IOL in the bag. If you are putting an IOL in the bag, it should be a foldable IOL, and if the IOL is not in the bag, then it should be a 3-piece IOL. And I mean, there are so many techniques that we've learned from Amar sir that in case you have a complication, then you can go ahead with glued IOL techniques also. So for the patient safety, having a vitrectomy setup, having standby lenses is extremely important, because for the want of a lens, you should not be compromising the patient.
Thank you, madam.
Thank you.
Yeah, thank you. Our next speaker is Dr. T.P. Lhane sir, our mentor, teacher. He is going to talk on a hard cataract. What will you do? Yeah. Sir is a Padma Shri awarded scientific, academic, and great social worker of India. Thank you, sir.
Thank you very much. इसको थोड़ा हटो. Thank you. Good morning to all. Thank you, Navneeta and Ragini, and thank you, Amar, for coming in the morning, and all my friends who are there sitting in the early morning in the Jaipur. So this is regarding the cataract that you and I do every day. So what I am going to speak is about the hard cataract, and this hard cataract can say the what you can do in the hard cataract. See, this is the rexis I am doing, and once I do the rexis, I have seen the always do slightly larger rexis when it is hard cataract, and better is to go for the, can say, the trench, because it is safe. So, and once it's a trench on both sides, it means if you are trenching, you trench it on the both side. So what happens if you trench it on both side? Then I am making the two pieces, but here the trench should be deep. If the trench is not deep, and then if you are making the two pieces, two half of the nucleus, then you will be unable to do it. And once if you are not doing it properly, then complete cataract, it means total surgery will be difficult. It means then you will cut somewhere, you will not cut somewhere, and the multiple pieces will be there, and that will trouble you. So it is always better कि whenever you are making, see here. So you have made two, see here, go down, and you make two pieces up to the center. Can you see this? Basically, and then once you have made the two pieces, then the chop or anything can be done. But if you are not making the two pieces, then that type of phaco is difficult. And see, now again the remaining part I am taking and removing it. It means though it is any type of cataract, you can definitely do it. Now see, this is an can you see this? Now in this, if you will see the cataract, I am making the chop. Now see, in the chop, what is important is the phaco tip should be in the center. Why? Because this 4 millimeter cataract in the center is deeper, it means the breadth is more, and hard. So it catches, and your tip should be away from the 4 millimeter. It will enter inside the substance of the nucleus. If you are doing the vertical chop. You are doing the horizontal chop, then your tip should be blunt, not sharp tip. And if you are doing the vertical chop, tip should be sharp. So this sharp tip you will see, can see the nucleus is brownish in color. And after that also I am putting the chopper inside, and once it goes inside, then I can definitely do the, see here. Now see here, now I am going in, and can you see it has made two pieces. So this type of chopping, can you see here again I am going, and you see the other I am making the two pieces. It means my phaco tip is going in the hard substance, and your tip should be down, not horizontal. So slightly you can say some part, 1 millimeter part of the nucleus, it should go below the 1 millimeter part of the nucleus so that it holds properly. And if you are going, you can say horizontally, then it doesn't hold, it comes up. So that breaks the, you can say the commitment up, you can say this. Now see, this is the another type of cataract. You will see it is a hypermature, and now what I am doing, can you see this? So here I am going in, and once I go in, here you will see, and then I am making the piece. It means whenever you should be confident that yes, can you see this? You are inside, and once you are inside, then you can make the piece of the nucleus. Otherwise, see here, again you will see, so whenever I am, now can you see this? I am going in and making the piece. It means though I am doing the chopping, I have done two halves of the nucleus. Can you see this going inside? So whenever I am making this type of, you can say the chop, I will make a chop where I will penetrate the tip or phaco tip inside, and once I penetrate the phaco tip inside, then I will do the other chop. Can you see? Now here you will see, I am going, can see my tip. Tip is slightly down to the edge of the nucleus. It is not at the edge of the nucleus. So it is below the edge of the nucleus. And when it is below the edge of the nucleus, then that will, you can say, hold the nucleus there. And once it holds the nucleus there, then you can definitely go ahead and do it. See here now. Can you see this? It has gone in, and then piece is made. It means whenever you are making the pieces of the, can say the nucleus, and then you go slow. Phaco is not a fast procedure. Phaco is a technology that helps the patient, and as it helps the patient, you should have a patience. So that is very important. And see here, slowly, and I have completed that. Now this is the another, can say, Margagnane. I am trying to do the rexis. Can you see this? And see the fluid is coming. See the capsule. Can say so many calcifications of the capsule. And then again, you can see this. All calcified capsule. And nucleus, you will see it is shrunken nucleus. Margagnane cataract. So here I am trying to cut the, you can say, this is a, can you see the zonules will be, can say loose here. And can you see the zonules are coming? Forceps I am using. But after that also see here, I am trying to use forceps. Can you see this? And I am trying to do the rexis. But it is not happening, so I am cutting it. It is a fibrous area. I have cut it. Now once I have cut it, see the nucleus. It has gone in one corner of the eye. When it has gone in one corner of eye, means if I will operate this with the phacoemulsification, this will go in the vitreous definitely. Because see what has happened, why it is going there, because zonules are loose. Zonules are not, you can say, strong here because of the hypermaturity. And so here again, you will have to think that yes, I can do it, go for SICS, or then remember Amar, and just once you remember him, then you will remember how to go. See here. Now I am bringing this on the anterior chamber. Small lens, I am bringing in the anterior chamber, and once I bring in the anterior chamber, then I will support the capsule by the Amar technique, by the lens. So this lens I have implanted before any PC tear occurs. So prevention is better than cure. So here now see, once the lens is there, my confidence is increased because I know there is a lens. And once I know there is a lens, though it is, you can say, very, it is a hypermature one. You can see this all, can say pieces I have removed. So it is possible with the technique of Amar to remove this. Now this you see, this is unedited, and I think you can see this thing is that Rexis is made, and whenever you are doing the phacoemulsification which is in the hard cataract, it is better to have 5.5 millimeter Rexis. If it is a small Rexis, then it tears from the behind because you are forcing it, and because of that there is always a tear in the posterior capsule. It has happened because your Rexis is small. So always better to have a Rexis larger, so it expands in the periphery and automatically you can do the phacoemulsification. Now see, this is a phaco I am doing. See here, and here you can see the once I am entering inside, then you can see these are the leathery fibers. Can you see? These are the leathery fibers which are there in the nuclear cataract, and that you will have to separate. Can you see this? Again I am going in, and you see sometimes what happens, if you are not proper, you can sometimes tear the anterior capsule also. So you will have to very careful, and then you will know that it has extension has happened and PC has tear. See here, again you will have to catch it properly. Can you see this? And then you will have to make a separation. Can you see? Again I am going in, and then I am making the pieces. It means in such a hard cataract, it is always better. Can you see this? To make pieces separately, and now you see I have completed it, and then I am just lifting one piece. Now it is not lifted because here the tip of the piece, can say, is attached at the hard nucleus. So there I am separating it, and then once it is separated, then I can, now I am doing this is a horizontal chopping. As I lift, there is a space because I have removed one piece, and because of that I can do this horizontal chopping. Here you will see again I am doing it, can you see this? I can do it the chopping because the debulking has happened because of one piece is removed, and then again you will see I am removing the another piece also. So this has completed this. Now the another cataract you will see, it is an intumescent one, and I am doing the Rexis. See, the Rexis always can say you will have to do with the forceps is always better. It gives and now you will see what has happened. It is a Rexis, but the nucleus is soft one. This nucleus, can you see here? It is a soft one, and so though it is intumescent, it is a soft one. Can you see this? And then it is possible to make the pieces. So here there is no struggle in making the pieces because this is a soft nucleus, and in the soft nucleus it is very easy to make the pieces. So I have completed. Now here you will see what I am doing is this is the, can say, staining. Once I stain it, then I am making the Rexis. So this is the Rexis. I made the, can see that I am using and when you are staining, stain it for more than 60 seconds so that helps in the tear. So otherwise it will only stain and not help in the tear. So wait, and then in the mature cataract always better to stain for 60 seconds. In 17 seconds normally it stains, but better to stain it for longer. Now here you will see I have stained it, and you will see my Rexis also, and just removing the cortex, cutting the cortex, and this is can say soft cataract. And then I'm just, can say, like an aspiration, I am just aspirating this soft cataract. You see this? It is always better to aspirate, and whenever you are doing this, you must know the anterior chamber depth. Otherwise, sometimes you may tear this PC tear. Thank you very much. Now
Thank you,
the
sir.
second talk is
Subluxate.
Dr. Agini Parekh. She has done 85,000 cataract surgeries, and highest maybe in the women in the world, and she will present the posterior polar cataract. Dr. Agin.
Thank you, sir.
Thank you, sir. Such wonderful teaching videos, and of course, you are my teacher, and I learn from you. Posterior polar cataract. So, when we start surgery and we used to be operating on tables next to each other, I used to always cheat and give all the hard cataracts to sir, and I used to take the soft cataracts, thinking they're very, very easy. And then when you start surgeries, you realize that it may look easy, but posterior polar cataracts are something that you have to be very, very careful with. Posterior polar cataracts, as you can see here, this is a lovely glow. The rhexis is very good. The patient is very young though. And these cataracts are usually complicated. Nowadays you see a lot of patients taking steroids and all that. And here you can see what has happened is when you try to do phacoemulsification, this is like a saucer effect, which is something that you don't want. Because if you go very deep, you may not realize that you are going up to the PC, and you may chop the PC itself. So though this looks very easy, here the separation is very difficult, the nucleus is very soft, and you have to use a blunt chopper or you have to use a IOL dialer to do the phacoemulsification. What remains over here after phacoemulsification, because we have done essentially a hydrodelineation and no hydrodissection, because you don't want any fluid to enter into this small, and as you can see over here, there was a small pre-existing defect which has now expanded, and you can see the tear, the PC tear. So there is a lot of epinucleus which is still remaining, and you do not want any piece to go inside the vitreous, so you have to be very careful. Again, the AC maintainer helps over here because it maintains the anterior chamber. As you can see over here, you have to deal with this and the vitreous. Be very careful to not tug the vitreous so that there is no pull on it. And once this cortex is removed, it is essential to do a vitrectomy. A swab vitrectomy and all will not work, but a proper vitrectomy, anterior vitrectomy, and then using tricot and then putting the IOL. Now here there was a bag and it was safe to put in the IOL, as you can see over here. This is tricot to see if there is any vitreous, extremely important. I remember when I was reading Jaffe, it is very clearly said in Jaffe that it is the vitreous where it should not be which causes the problems and not the vitreous loss per se. So that is very important. So when you are doing this, you have to visualize the posterior capsule and the plaque relationship with an ASOCT. So which is very, very important. As you can see here, as you can see over here, you may feel that you don't have access to an ASOCT, and slit lamp doesn't tell you the exact way, but spending this money, even if you have to get it done from outside or at your own center, you can see that the ASOCT images are very clear and very sharp, so that they will help you during surgery. So if you see these images, the grade 1 capsule, the grade 2 capsule, and the other capsules where the risk of PCR is very, very high. So if you know what you're facing, then you are mentally prepared to face a PC tear. And I'll tell you my own thing, even after doing thousands of cataracts, what phobias you have as a child continue. So similarly, the first year residency, there was a big scare, vitreous loss, vitreous loss. So, that scare remains with you that, oh God, you had a vitreous loss, you feel guilty, you blame yourself. But with a posterior polar cataract, it's not your fault if there is a pre-existing defect that the vitreous loss will occur. So it's okay. Now this is the second patient, as you can see, the hydrodelineation that is going into the substance of the nucleus, not between the capsule and the posterior capsule and the anterior capsule, so that you are not extending the tear, and then to do a phacoemulsification. So as you can see again over here, These cataracts are extremely soft, and sometimes in older individuals like this, they may be amenable to a stop and chop. Sometimes they may not be. So depends on the age of the new patient, because here, as you can see, you try to do any phacoemulsification, you have eaten up most of the substance of the nucleus, and then this whole thing is moving as a whole, and you are not able to get any pieces or divide it. And you should have a lot of patience to divide it till you get this one piece. Now the minute this one piece is out, then it's much easier for the other pieces to be rotated and brought into the center. As you can see over here, you have to remain in the center to do this, because if you go into the periphery, there's even thinner nucleus. This is the epinucleus which we are rotating and trying to do and remove in the epinuclear mode of phacoemulsification. We use the Centurion machine, but any machine that you are comfortable with is fine. Lifting up the epinucleus and gently aspirating it is very, very important. Your foot control is extremely important here. Again, the AC maintainer and the single port Dr. Lahane cannula that we see. Anything that is good in your hands, anything that you are comfortable with is fine for any step of phacoemulsification here in cortex removal, as long as you remember to keep the ocular structures, that is the cornea and the iris, safe, and the safety of the patient in mind. So that is extremely important over here in these type of patients. Again, the rhexis here, the rhexis is extremely easy because of the fully dilated pupil, the excellent glow, but the problems start afterwards in managing the cataract. So you can see the ring, but you have to be very careful to use small amount of fluid, and if you use a nucleus salute, and to bring this nucleus by the carousal technique completely above and use aspiration more than phacoemulsification, because these cataracts are extremely soft that you don't need to waste extra ultrasonic energy damaging the endothelium. And as you can see, this is completely flipping the nucleus, or the nucleus salute, as Dr. K.K. Mehta sir calls, and I'm waiting for him to come to be a part of this course and to remove the nucleus. You have to be careful. This is in the supra iris plane, so you need a good viscoelastic, because you have to treat the corneal endothelium like God and be safe. So this is very, very important. Again, a soft cataract, as you can see. The minute you try to do phacoemulsification, there is this saucer effect. So what is actually, you have to separate it completely and bring it out at a whole, which would be much safer than trying to do a stop and chop in these type of. So this is something that is not desirable. And exactly, this is what we should be doing, trying to lift this as a whole, because this is not going to be amenable to a stop and chop method. This is much easier managed by just using aspiration, as you can see over here. It's extremely soft and it can be aspirated. So the most important thing is, though they look very easy, they're more likely to get complicated than the hard cataracts. We must be prepared for secondary IOLs, like we already discussed for the previous segment. And there are multiple ways you have to keep innovating, and you have to control your machine and not let the machine control you. Here I would like to say that everybody is a phacosurgeon, and there are lots of techniques that you might have devised to manage these cases, but one must keep the safety of the patient in mind as always. Thank you so much. If anybody would like to add or give some tips, they are always welcome, or questions are welcome too. Thank you, sir. Thank you.
Thank you, Ragini. I think it was a very good demonstration of the post-polar cataract. Only thing is, when the saucer happens, in that when you are doing the, can say, hydrodelineation, and if it is not complete, so, and the nucleus is already soft nucleus, where you can't make the, can say, the chopping of the nucleus. And so if it is not rotating, then there is a problem. So you can use the visco there, and you can separate it, or where it is attached. So there you can separate it, and then you can eat it. What she did is very correctly, yes. So,
Sir, I would also like
yes,
to ask
please.
that if, yes.
Yes, please. Yes. Mic,
Can
mic
you,
चालू
can you
करो.
switch on the mic, please?
Somebody help him.
No, there must, yes.
Okay. Yes, go ahead. Mic, please. इसका एक बाजू में करना है. ये है ना? ये बाजू. Now go ahead.
Morning, ma'am.
Morning, sir.
Sometimes it happens that I have faced this situation that this posterior polar cataract, not every patient present very early. That you have just endonucleus and underlying posterior polar cataract. Sometimes the patient present with NS3 and NS4, even 5, with underlying posterior polar. You start doing the cataract surgery, then you realize that you have caused the rent, region you don't know. So in such situation, how do you tackle posterior polar cataract?
Sir, you know, a proper slit lamp examination with the patient dilated for every patient before surgery is very important. And as you rightly said, that patients who are taking steroids, patients who are asthmatic, they may come at a very late stage. And it has happened so many times that even in mature cataracts, when you are doing it, you realize that the patient had a pre-existing posterior polar with a long duration where there is a small pre-existing rent. You cannot, so that's what I want to say, that if there is a pre-existing posterior polar cataract in a grade 2 or grade 3 nucleus, which you notice later on, any hydrodelineation or hydrodissection has to be very safe. We advocate multiple points of hydrodissection or delineation so as to not overload the capsular bag with lots of fluid. Like if there is a bag with too much of fluid, it has to give away at the weakest point, which would be the defect or say attenuation of the capsule. So that is one thing. And in these patients, or in any case in your OT, having a vitrectomy setup where you are, and like sir said, that in case you are doing phacoemulsification and if you find in a nuclear cataract that there is a defect, it's like a phaco fracture. You can either convert it to SICS or bring the pieces anteriorly, supra iris plane, and then do emulsify it, protecting the corneal endothelium. Or if you can bring the whole nucleus, then again the scaffold of Amar Agarwal sirs would be very good. So you have to be, you have to be attentive to any complication that may occur. These, like you said, obvious soft cataract with a posterior polar element would be again easier to manage than a nuclear cataract with a posterior polar surprise element. But the slit lamp examination of the patient by the surgeon himself, not by the assistant or by the optometrist, is good in every case, so that you know that what you're doing mentally, sir.
I think what he asked and what she is very correct, but she has also shown us the ASOCT images. So when you are, I can say, in the doubt, when you can't say anything, in that it's better to classify the ASOCT images. In that you can see the poster capsule, and there nothing you can do some extra. But here you know that yes, there is a PCTA, and you are doing it with the caution. So you will have to take a caution and do it. So that is what. Otherwise, see, if it is opaque cataract, how we are able to see the PC defect? Not possible. So better is to go for the, you can say the this UBM image and ASOCT image will definitely help. Thank you.
You know, there's something also that I would like to add, that there's something in our setups, in all our setups, that we call as the academic OCTs. Like, sometimes you are scared, and which is very regular, of patients running away before cataract surgery when the charges are very high. So what we do is, we do not charge the patient for it, but for our own sake, we do these ASOCTs or OCT maculas just so that we can give good results to the patients and we can protect ourselves from any complications, or we can tell the patients that this is likely to happen. So, it's a good, I think OCTs are an integral part of our setups as much as the microscopes and phacoemulsification machines are. Sir, I would also like to ask you that if you have a saucer, Amar sir or sir would like to comment that, can you go in and either do a small hydro procedure to make the nucleus free, or would you like to use visco?
You can do the visco procedure.
Okay, thank you, sir.
And now I will call upon Navneet Tosniwal. he is going to talk to us on the, if there is a posterior rupture, capsular rupture, how he will go ahead. Navneet is an excellent, can say the surgeon. He is also a teacher of phacoemulsification, taught more than 150 students, and he is from Solapur. Navneet. उधर जाना पड़ेगा.
Thank you, sir.
हाँ.
Thank you, Lanet sir, Ragini madam, for giving this opportunity.
हाँ.
Yes.
Now till the
Yes, it is.
Amar, if there is a saucer, what he will do? Ah.
I think what Professor Lahane said was a very good idea to do some viscodissection, which will help bring it out. He's ready.
Thank you. Navneet, go ahead.
Yes, sir. Posterior capsule rupture, as we have just saw the presentation of the posterior polar cataract where we are assuming. Now this presentation is when everything is normal and something will happen, then what to do? You can see here, this is the typical picture. When you see while removing the nuclear pieces, you see the typical holes of catching the nucleus. Maybe we use more energy, but you can see these 3 holes. This is very typical point in the teaching. When we see this picture, we have to be very cautious that might have something has happened. And now you can see here, still the pieces are there. I was in doubt that might be something has happened. Supracapsular plane, everything is doing. These are the last pieces. And suddenly, if you can see at 5 o'clock, while removing the last pieces, I pull the whatever the pre-existing zonules. That 5 o'clock, you can see the PCR has happened. Suddenly don't come out, put the viscose. But now this situation is, it is at the periphery with the phaco-tip, so it may be the punch-out lesion. So most important thing is the bimanual irrigation aspiration. Very controlled way, you can remove the cortex. See, whenever the PCR occurs, we are worried, vitreous, like that. But here, you can comfortably do your irrigation aspiration. Till now, there is no pull on a zonules. Till that time, you can safely do this irrigation aspiration. Because once we can do, here it has started, still I am controlling with my other instrument, that zonules, and I am trying to remove the cortex. This is very, very important. No pull on the vitreous zonule, so it may be the localized vitreous prolapse may be there. Now this situation, we are in dilemma what to do, where to go for directly to put IOL or to do some vitrectomy. This is always the question for the anterior segment surgeon when he is doing as a normal case. So here everything looks nice, and here I have taken the chance to put the hydrophobic lens, which I have decided that you should take the precaution that haptic should not go or push in that location. So just now I asked the madam also what are the choices of lenses. So always keep the 3-piece hydrophobic lens ready. Now this is the case, started, no visualization, pressure on zonules, and when you don't see, don't do, and suddenly something has happened. Now here, the trench, during the trench, something has happened which looks like posterior capsule rupture. This is the Toshniol pre-chopper to divide. Very important again, because of the phaco tip, the PCR occurs. So it will be not very critical So just go ahead, continue, keep it in mind. You can convert the case anytime. But still now, there is a control. I am in the center, removing the pieces, so there is no vitreous loss as such in the AC. Again, lift it out, another piece. This is very, very important. If your phacofluidics is working at a supracapsular plane better way, it is good. It is a very big piece. That's the reason I am trying to chop. First piece I have without chop I have removed. You have seen the excellent chopping things by the sir just now. So try to, and don't see that you can divide it continuously, because this is called as a partial chop sometimes in a hard cataract, so that your apex will get attached with the apex, and when you are trying to remove one piece, other piece will automatically come. And so the important point here is that if phacofluidics working, flow rate is working, pieces are coming towards the phaco tip, it means that although there is a PCR, still it is, you can continue with that. Don't come out suddenly, viscoelastic, we have to put. Welcome, sir. K.K. Mehta, sir, welcome.
Ah, sir, please come.
And then again I am trying with the coaxial bimanual. Already I have demonstrated. I am trying to do with the coaxial, and you can see still the fibers are coming, and you can see the rupture in the center where with the phaco tip during the tranche the PCR has occurred. So vitrectomy, adequate vitrectomy, I will use the word here as an anterior segment surgeon, anterior or up to the mid, maybe at the anterior phase of the mid only. You can go ahead. And with this rupture, I thought that I will convert it. A single piece hydrophobic is better, but with the injector system, it may be difficult sometime. And then this 3-piece hydrophobic lens, I'm putting, looking in the back, because the center only, it is a rupture. Again, after that, you can go behind the lens and you can do the anti-vitrectomy. So adequate anti-vitrectomy, again suturing, all these things are very, very important. Here you can see while removing the last pieces, direction of the phaco tip is downward. That's the very difficult and wrong thing. And suddenly the PCR occurred with some pieces. This was very old presentation, and at that time, sometimes your anterior vitrectomy working or not working, I'm trying to remove the pieces which is stuck. So I have used here the venous scissor to cut the vitreous phase to remove at least these small nuclear pieces. So with the visco expression, you can remove these nuclear pieces out. This is not an ideal way. This is a crude method. But on that situation, in that situation, practical things, you can do that. And here the sir has shown you can put the IOL before removing these things. I have increased the thing and I have removed the nuclear pieces. Then vitrectomy, ideally you should put the Orocort and all that solution to see the vitreous space. But I have already, this is a very old presentation, and you can see the control face is there, and you can put the IOL. In this situation, you can take the suture. That is very important, because already I extended. Hypotony is not good idea. So you can take the proper suture. This is the way. So PCR can occur anytime. No worry for that. But you should be ready with some lenses. You should know that your vitrectomy is working or not. Thank you, sir. Thank you for your patience hearing. Thank you, sir.
Now, IT team, please come here. ये लगा दो. So basically, the KK sir has came. but he is finding his presentation. So I will present my presentation, that is a subluxated cataract. Huh? Okay, thank you very much. So इसको थोड़ा सा सेंटर करते हैं. So this is the, can say the subluxated cataract. हाँ, क्या हो गया? एक मिनट इधर आ जा जरा, मेरा ये उधर. हाँ कर, he will do it full screen. मेरा ये उधर है. Okay, हाँ आ गया, हो गया. हाँ, चश्मा नहीं था. Okay, thank you. So I am doing the, can say the, I have put the, the CTR. Always we discuss when to put a CTR. So now here the cataract was very much subluxated, and so I have put a CTR beforehand only, so that that will support the my phacoemulsification pressure. And now see the, can say just I am doing the phacoemulsification here. Can you see this? And I am trying. So can you see the lens is moving? So whenever I am doing it, the lens is moving, and it is not much supporting, because though there is a CTR, now here there was no hooks of the, can say, capsular hook. So I have used the, can say, iris hook here. So if you, it is you are doing, and sometimes such type of problem happens, I have used, and always better to use the capsular hook, but as the hooks were not there, and then I have done the, can you see now? I am doing the trench and it is supporting. It means the stability, I have brought it back, and just by, you can say, slight, you can say, concentration, this is possible, and the it is brought it back, the, and I am doing the, now here I am not going for the chop, I am going for the, you can say, trench, and then making the pieces here. Again I will see the, here I want that the pressure should not be much more on the capsule. Here you will see going very slow and using minimum, you can say, the pressure, and can say how slowly. You can see I am not doing it very fast. Slowly I am doing the phacoemulsification, and see here again I am doing it. You can see here gradually the phacoemulsification. It means in the subluxated with the two support I am doing, and you can see my chopper is a blunt chopper. So again the, as the posterior capsule is weak and loose, the sharp chopper may tear the PC. So I am using the, this just to support it and complete. Now once I have completed, then this is the aspiration, this is a cannula that can be used on any side, made it in 1996. It is a sand polished, also it can, you can say, the use for the posterior capsular and anterior capsular polishing. And then I have implanted the lens in the back, and then I will remove the hooks and everything, and the lens is inside the bag. So it means whenever you are doing the subluxated cataract, it is better to take care of this cataract, and see the lens goes in the bag. So this you will see another lens subluxated cataract. You can see here it is a, you can see the, I am doing the rexis, old video, and you can see this, the rexis I am trying to do. The, here you will see the rexis, and once I have completed the rexis, then you will see the, I have done the hydrodelineation here, And you can see the lens is upper portion, you can see it is a subluxated one. So what I am doing is, again you can see this lens I am trying to separate it from the owl capsule. See here, doing the hydrodelineation, and here again you will see the lens. It is not a hard cataract, it is a soft cataract. And what I am doing before doing anything is separating the lens. Can you see this? I am separating it by the, can see this cannula, and this lens is, see here, and then I will go for the phaco where the pressure will not be there. This is the phaco, might be done in the 2004 or less than that, because this is the APPA machine I am using that time. So you can see the defect there in the superior portion, but the nucleus is totally separated, and so it is not going on that side. I am doing away from the defect area and completed this one, and then I will put a CTR. So before also you can say put a CTR, or after that also you can put a CTR and then support it. So here I am supporting it, and you know the technique, how much you can say it is a gradually you will have to support it. Don't go fast, otherwise that will tear everything. So here I am just doing it, and by the, you can say, dialer, then I can just put it inside. So I will use a dialer here, and by the dialer, then it will be implanted inside. So I am using forceps, dialer, everything. And then the only thing is that once the CTR is there, the capsule, this cortex removal is very difficult. Every time CTR will come with you. Every time CTR will come with you. So that is what happens. So it is always better to remove the cortex as much as possible, and then do the put a CTR. So that is always good. But if there is no support, it is better to implant the CTR and then do the can say aspiration of the cortex. So it is okay, but you will have to go slowly. You will have to just pull it and then aspirate, pull it and aspirate, pull it and aspirate, like that. So you can complete it, and that is what happens. And now I will invite last talk of the session, Keki sir. Keki sir, as you know, is a doyen of ophthalmology. He is my guru, who taught me the phacoemulsification in JJ Hospital, and because of that I learned the phacoemulsification. He sat, I did 13 cataract on that day, and that was 95, I think he taught me the phacoemulsification. Thank you, Keki sir. Go ahead. He will show us interesting phaco cases. Keki sir.
Thank you very much, Dr. Lan and Dr. Rageni, for inviting me to this course. I was going through what has already been spoken yet. I should have come a little earlier, but I didn't realize traffic in Jaipur is like traffic in Bombay, almost impossible to predict. Having said that, I'm going to talk to you on two interesting little things. First is, as I said, my topic is interesting cases, so let me shift down to interesting cases rather than trying to duplicate what people have already spoken for you. I'll try and find you things. First of all, let's talk of something. Now, when you are presented with a case, you've done a good phaco, and you've got, and I mean, you've done, the case is presented with a good subluxated lens like this. Now, the question is, how are you going to really manage? If, as you noticed, it is more than 180 degrees subluxated, life is going to be miserable. So, how do you proceed? The answer is very simple. Let me show you some simple ways of handling it. No complicated techniques. It is still stable. Check, first thing you check when you see a subluxated lens is how are the other zonules. If the zonules are fine, you can proceed a little further. So what you make is a small little nick, and then you do a small rhexis. Doing the rhexis, you have to be a little careful that you don't exert traction on the areas which have already been subluxated. Having done that, the next step, of course, is very simple. You put in your hooks. But first thing, you complete the rhexis and be sure that you get a nice round rhexis, because you're going to put in a capsular tension ring. So you have to be certain that you're going to manage comfortably there. Having done that, the next step which you do is make little openings on the side. I prefer to use diamonds. I think really they give you a nice square cut incision which self-seals, which is really my reason for using them. Now we utilize hooks. People all recommend that you use capsular hooks. I don't use capsular hooks for the very simple reason I think they are much too big and really they are not designed for the capsule. The regular hooks work better, which is why I prefer to use the regular hooks. You want to pull on the capsule, you don't want to have a band which pulls all the way in, which is the thing I don't like about the capsular hooks. They're too big and too unwieldy. So first thing you do is then you put your capsule hooks and pull your bag back to the place where it should have been. So you know that you are now standing there. Now you do a hydrodissection, remove the little hard lens which is there, and then do a little phacoemulsification. Chop it so it splits in the middle and gradually do it out. Now this is what we call as a slow motion phaco. You run everything slowly. You try any funny games with the subluxated cataract and you are in trouble. Having done that, you can remove your cortical material inside without too much trouble. Please note, I only use 2 hooks because that is the only 2 places where you require to support it. There's no logic in putting hooks everywhere around. You use a capsular tension ring. I like to use this injector, which is made by Morcher. You just put the loop in, and you inject it. Now the important thing is you should inject it in the place where the subluxation is there because you want to balance it out there. So you spread it out. As you spread it out, it opens the bag and pushes it out. On the other hand, you utilize and drop your loop in. Once the loop is in, now you know that it is comparatively stable. Now comes the interesting part. Be with me. How are we now going to fixate it on top? You have your regular lens. Now you put your regular 30 gauge Prolene suture, push it through the injector, put your lens there, suture it to the end of the injector. So you got the needle coming out, you got the suture coming in, and you got it tied to the end of the injector. Amar, how are you, my friend? I did say saw you. Having done that, the next step is again very simple. You bend it across. Push it out into the same opening which you have made. So in front is your needle, back is your lens, and there are your loops. Press it into place and inject it. First pull out your needle. Then take your needle and inject it. As you are injecting it, the needle and the bag will come out. As you are injecting it, then you take the needle and you go through the bag, through the opening on top, through the sclera. Now remember, at the end of the needle is you already tied it to the lens. So when your needle comes out and you inject it in, you now have a lens injected inside a subluxated bag which has been sutured onto it. So 50% of your work is already done with no hassles and no difficulty. Pull the needle out. As you pull the needle out, the lens will slide into the bag. You simply have to slip the lower loops in. Now this is the needle which you've taken out. Now you have 2 options. You can either suture it there, or the simpler thing, which is now what I've started doing, is just do 3 passes through the sclera. That's more than enough. It supports the suture and enables you to then handle it. Before you do anything else, remove your capsular tension hooks, your hooks which you have placed inside there. And now as you pull the suture on top, the lens will move into place. Move it until you get it into proper place. And just go on increasing the tension each time. Do it gradually. There is no hassle, there is no hurry. Having done that, you can either suture it, as you can see me doing it here, or pass 3 times through the sclera and just cut the suture and don't do anything else. That is more than enough to support it. There is no knot, nothing required, and it stays stable. Here I'm just tying a knot and slipping the knot in. At this particular stage, we will now be injecting a bit of steroid inside and doing a core vitrectomy to make sure that there is no vitreous left over, which I have removed for the sake of. So this is a simple and an easy way. Now let me show you something a little more interesting. You got a subluxated lens. Can you do it with a catalyst? I use a catalyst quite extensively. I think it's a great tool. It makes life very easy. All you need to do is to center and stabilize it. Move it into position. Dr. Lane, have you got time? 3 minutes, good enough. I'll just show the interesting parts. So that is the catalyst, you set it on. I'm just going to show it for a few seconds how the setting is done and then show you what really you see in the view screen of the machine with the subluxated lens. Once the scanning takes place, it's a very good scanning system. This is a catalyst which seems to work very well. And as you will now notice here, the lens is completely subluxated off. The machine will give you a warning that your lens is offline and you have to now center your cutting points onto the lens itself manually. This will enable you to get a perfect rhexis on a subluxated lens, which otherwise is extremely difficult to do. Let's go forward a little. That's your subluxated lens sitting there. And this is the catalyst which works on the surface. Once it is done, this is how it will appear to you. It's worked on the surface of the lens. The lens is now subluxated. You can see it shaking, so you know that it is subluxated. Now comes the interesting part. How do you manage to do it without dropping the lens inside? यहाँ तक तो कर दिया है, अभी और क्या करना है? So you make your 4 side ports and you insert your hooks inside and stabilize your bag. First step to do. And then after that you enter inside. Rather than trying to shove a knife in, I always like to put it in like you put a hand in a pocket. That way there's no pressure anywhere and it's more controlled. When you push it in, there's no control. It goes in halfway and then suddenly slips in, which is a problem. Bag stabilized, you do a hydrodissection, remove this thing remove it from the top. Use a final hook on top. Now at this stage, what you now need to do is to prepare place for your phaco. So you remove one hook from the side and place it on the side. Next step is the capsule tension ring. Same thing with an injector inside. I like to use this injector which I mentioned a little earlier. It makes life easier, it is much more controlled. Control is everything about life is control. If we can control everything, life is great. Here you just aspirate it. Usually subluxated lenses are very soft in the middle, which is, I think, the good Lord trying to help the poor surgeon at the bottom. कि आप यहाँ तक तो फंस गए, let me help you. Once you go up to this point, clear it off completely. And slow motion phaco. Suck it out. inject your ring inside. This is the ring going in. You are wondering why I have kept the left side hook open, because very often the ring slips onto the hook, making the hook very difficult to remove later on. So you loosen the hook at the side where you're going to slip your ring in. That's a little tip which you can utilize regularly. And this is a Rayner lens. It has got a good support, especially in the subluxated lenses, which I like to do. So you inject your lens inside and stabilize it into place, which makes life easy. This is now stable. At this point, the next step basically is to inject a bit of steroid and do it. But that is exactly how the system works. So there are two little tips which I've tried to show it to you, which I think will prove to be useful sometime or the other when you get stuck. Thank you very much.
Thank you very much, sir. Thank you, everyone. My teachers, Padma Shri Dr. K.K. Mehta, sir, Dr. Lani, sir, Dr. Amar Agarwal, sir, who were here, and I'm sure that all of us gained so much from this. Dr. Navneet, who is my brother and friend, I would like to request Dr. Amar Agarwal, sir, if you can please come up for this photo, which is very important to us. Thank you, everyone, for attending this course in the morning. I think, and I hope that we've given you some things to take home. I'm sorry for this 5 minutes because we got the hall 5 minutes late, and I think beautiful cases by Sir and Mehta, sir.
Yeah.